Hi, everybody. I'm Adam Hoffberg, and this is the Rocky Mountain MIREX Short Takes on Suicide Prevention podcast. We are joined today by Colonel Carl A. Castro, who is a PhD, and Colonel Castro is a pillar of the military suicide prevention research community and has served many roles, including the director of the Military Operational Medicine Research Program, which is part of the U.S. Army Medical Research and Material Command. He's also the chair of the Joint Program Committee for Operational Medicine, which is part of the Department of the Army, U.S. Department of Defense. Colonel Castro is also a professor with the School of Social Work and director of the Center for Innovation and Research on Veterans and Military Families within the University of Southern California. Colonel Castro also serves as the chair of a NATO research group on military veteran transition. He is a Fulbright scholar and a member of several other Department of Defense research advisory panels that are focused on psychological health. So he has quite a lot going on, and we're very appreciative for joining us. Thank you for joining us, Colonel.
You're welcome.
I really just wanted to start by talking about your distinguished background. You clearly have a passion and commitment for military and community mental health, and particularly suicide prevention. Can you just tell us about your service and what led you to your current position?
Well, as you noted, I was a colonel in the U.S. Army. I retired about 3 years ago, and I'm now a professor here at the University of Southern California. And one of the things that I've had been able to maintain over the years is my involvement in some of the NATO research and technology groups. And I currently am chairing a NATO panel on military to civilian life transition because, as you know, there's a lot of struggles that our service members have when they leave the military culture and then rejoin the civilian culture. So we've been focusing on sort of understanding these dynamics for probably the last 5 years. This work I began while I was still on active duty, and I've continued it in my academic career.
Colonel Castro is also a professor with the Suzanne Dworak Peck School of Social Work and director of the Center for Innovation and Research on Veterans and Military Families at the University of Southern California. Okay, so thanks for that introduction, Dr. Castro. And just wanted to now talk about some of your scientific work. And I understand that you've published over 150 articles, so it would be impossible to get through all of that today. But I do want to focus on one of the reports that you published in 2014 that really just focused on suicides in the military, articulated some of the theories and explanations that have been put forward to explain why there is a higher suicide rate in the Army than there was in the past. I think it would be great to just sort of start by touching on that before we get into more of the prevention side.
Well, thank you. One of the things when I was on active duty is, this is no secret, it's been well publicized in the scientific literature and in the media, that the Army in particular had gone through this tremendous increase in suicide over the last 10 years or so, depending on where you're counting and where you're looking. And one of the things that, of course, our senior leaders in the military were very interested in is getting those suicide rates down. And of course, trying to use a scientific approach, we first wanted to know, well, what was causing the increases in suicides? And then maybe we could look to use that as a mechanism for an intervention. And one of the things that we quickly realized is we didn't know why there was an increase in suicides. And because we didn't know what was causing the increase, we really had no idea of how to bring about a reduction in suicide. But this doesn't stop people from saying they know the answers. And, we had all kinds of theories ranging from it's hot in the desert in Iraq to there's not enough fatty acids in our food to increase in depression. The list just goes on. And while some of them may make some sense and there's some basis in the scientific literature, for others, there's just absolute no basis in the scientific literature for supporting them. So we quickly realized that we needed to have a very broad-based and very deep research effort focused on suicidality in the military.
That's helpful. And could you give us a sense of the scope of this research enterprise within the DoD? how much money is going towards suicide prevention research, and what are some of the areas that are being studied?
So I think there are three main avenues of research in the military that's focused on suicidality. So the main two that people have heard about is the Army STARS research effort, which is an epidemiological study. So a lot of folks think, oh, well, that's the study that's going to solve the problem with suicide. But epidemiology studies, almost by their very nature, never solve problems or develop interventions. What they do is identify risk and protective factors associated with suicide. And so we knew that we needed to have an equally large effort, similar to the Army STARS effort, in which the focus would be on developing intervention. And that's really where the Military Suicide Research Consortium came about. The goal of that consortium was to develop and validate scientifically based interventions for reducing deaths by suicide. And that could range from population level studies to effective screening to better treatments for individuals who were suicidal. And so those are kind of the two main ones that folks have heard about. But there's a third one as well, and that is the Department of Defense has always maintained investigator-initiated research program. So you don't have to be part of the Army STARS program, nor do you have to be part of the Military Suicide Research Consortium in order to get funding from DoD. As an individual investigator, if you have a good idea, you can propose it to DoD for funding outside of those two main funding mechanisms.
Thank you. That's really helpful. And could you tell us a little bit more about your role with the Military Suicide Research Consortium?
Well, my current role is I sit on their scientific advisory board for about the last year or so, where I just give advice on things, from a military perspective, from a military operational perspective, on whether or not a particular intervention is likely to be accepted and adopted by the Department of Defense.
Thank you. As we've touched on, there's a variety of causes of suicide, a variety of factors that come into play, and so, of course, many different research lines to approach the issue. One of the questions we hear a lot, and I'd hope you could comment on, is the role of combat and the role of deployment in suicide and suicide research.
So that's a great question. It often comes up is individuals will say, well, the reason why the suicide rate is higher is because of, this persistent ongoing combat operations in either Iraq or Afghanistan. And what is the evidence then that either supports or doesn't support an argument on either side of that? Well, one of the things that people have done to look at this, they've looked at those folks who have deployed to Iraq or Afghanistan, and then they look at those who haven't deployed to Iraq and Afghanistan. And what do you think they see? What they see is that there's no difference in the suicide rates between those who have deployed and those who haven't deployed. And from that pattern, they conclude that combat or deployment does not contribute or isn't contributing to the increase in deaths by suicide. Now, those analyses that people have conducted have been rigorously conducted, and that finding is correct. But what is not being considered is two things. The first thing is it's a logic problem, and in some sense it's a logic problem based on scientific evidence. So we know, and nobody disputes this, that deploying to a combat zone increases the mental health burden of those folks participating in the deployment or in the combat operations. So that's known. No one disputes that. Combat, for example, increases both post-traumatic stress disorder and depression in those individuals participating in combat. That's not in dispute. What's also not in dispute is that dying by suicide is related to one's mental health status, particularly depression, and more recently it's been demonstrated for post-traumatic stress disorder. That's not in dispute. Well, if combat increases one's mental health burden, and mental health burden is related to suicide, why then are we not seeing a relationship between those who have deployed to Iraq or Afghanistan and suicidality compared to those who haven't? Well, one of the things we now know is that for those folks who have not deployed to either Iraq or Afghanistan, if you just look at that group and you look at those and the percent of those who have died by suicide, over half of the death by suicide and those who have never deployed occur within the first 2 years of military service. And this gets into something else that we'll talk about later, and that is, well, what's going on during those first 2 years of military service that puts this tremendous burden in terms of dying by suicide? But when you take out then that group, then what you see is that, in point of fact, deploying to either Iraq or Afghanistan does cause an increase in risk for dying by suicide.
That is a really thorough explanation. I very much appreciate that. And, just a quick plug to our listeners, if you have questions later on about that, we'd love to hear your comments or questions to help break that down. But I really think that was helpful. And I think, as you mentioned, we'd like to learn a little bit more about what is going on during these transitional periods, entering and leaving the service. And I understand there is a name for this theory. It's called military transition theory. Could you explain that a little bit more for us?
Yes, I'd be happy to, because as you know, I have been working on this theory for some time. And this is not a new concept. People have been describing the importance of transitions in life for some time. But we've never really talked about it in terms of the military per se, but more specifically around suicides. So if you think about what happens in a transition, so when you leave or when you join the military, for example, and when you leave the military, you're joining, in many sense, a new culture. So when you join the military, you're joining a different culture in all of the trappings of a culture. But most importantly is you're kind of, in some sense, giving up old friendships, old relationships, and you have to learn new relationships. You have to make new friends. You have to learn a new culture. And that's extremely stressful for some people. And the military does it in basic combat training where it's intense, it's 24 hours a day, 7 days a week, at least for the first 8 weeks or so. And then you gradually kind of get your individual freedom back. But early on, it's very intense, it's very immersive. And what we think is happening is it's those individuals who have difficulty forming new friendships, having difficulty forming new relationships, establishing new social networks as they join the military, are those who are at most risk for dying by suicide. And conversely, those who leave the military. So in point of fact, as I'd already mentioned, you have this big spike in suicides within the first 2 years of people joining the military, and you see a similar spike in suicide service members when they leave the military, because again, they're leaving a military culture they understand, and they're rejoining the civilian society in which they cannot really connect with the people who have not served in the military or haven't deployed to combat. And then again, you see, this spike in suicides then that tapers off.
Yeah, and I can see, again, knowing a little bit more about this theory, that this can then help us target or focus our efforts, knowing that there are particular time periods where service members and veterans may be at increased risk for suicide.
Well, exactly. And you know what the Department of Defense and the Army in particular have done, they just kind of, everybody gets the same suicide prevention training at the same time every year, regardless of where they are in their military career. And what we think it's best is to identify when are folks most vulnerable for dying by suicide and target the intervention around those points. So, for example, even if you look at the big risk factors like financial problems or intimate partner breakups and folks who are in legal issues, these are all around transition points as well. But if you just target those events, you're going to miss the bigger events that involve disruptions in relationships and social networks and connectedness to other people. And that's what we think we really need to focus on as well.
Mm-hmm. Thank you. So just shifting gears a little bit, but I do want to stay with this sort of these modern, more recent veterans of the current conflicts. Are there any particular factors? Again, we know a little bit more about the transition times, but what other factors may be at play here among our current era of veterans?
Well, one of the things that we always have to keep in mind is that in a transition, lots of things are happening. And transitions, by their very nature, are stressful. They're stressful by definition. And if you think about when someone leaves the military, what's changing? Well, their job's going to change. In most cases, folks who leave the military move to a different city. Sometimes it could be a city where they grew up, but oftentimes it's to another city. So they don't have a job. They're looking for a job. They're joining a culture where people don't really understand them because most Americans have not served in the military. They may have an uncle or a granddad who served in World War II or Korea. But for the most part, the American culture has no military experience or very little military experience. And then oftentimes these service members leave the military with unmet mental and physical health issues. So you have an individual giving up a job, leaving the military, and our research has shown that about 70 to 80% of service members who leave the military do not have a job when they leave. And in fact, they don't plan on getting a job for a while. So they have no job. They're trying to reconnect to old friends, family members who don't understand them, and they may have unmet mental and physical health issues. And since they're not working, financial issues are right behind. So all of these things can come together to create a very stressful transition for many of our veterans who are just leaving the military. And this stress then can result in dying by suicide.
Yeah, again, that's very helpful to think about it in terms of many factors coming together and the transition from military service being one of those precipitating factors that set off. Now you're looking for work. Now you're finding new social connections. Now you're entering new just physical spaces. And again, maybe this burden of unmet physical and mental health needs from military service or perhaps even from before military service.
Well, absolutely. And it's those who are entering the military, of course, we would argue is the most risk. Those leaving the military, those are the big ones, the big transitions. But we already talked about another transition, and that is those transitions around the deployment cycle, getting ready to deploy, returning home from deployment. These are equally important transitions, as are transitions such as just moving from one duty station to another within the military. All of these are very stressful transitions on top of the transitions that we all experience, like getting married, having kids, starting a new job or a new duty assignment somewhere. All of these events are very stressful, and it's very important that anytime anyone's getting ready to transition, that we're very mindful that this is when they're at most risk, not just for dying by suicide, but they're at most risk for everything that you and I can think of in terms of behaviors such as drug use, alcohol use, self-medication use, domestic violence, aggression, etc. So these transition points shouldn't just be viewed as suicidal point intervention. More broadly, they should be thought about as behavioral health care intervention points.
It's a great conversation point in the course of a clinical discussion, to identify transitions that are happening in the service member's life so that, increased attention can be paid and extra support is available if needed.
Exactly. And one of the things that we're also been tracking very carefully is those service members who have been, if you will, being kicked out of the military because the military is downsizing. And the military does try to offer support for these service members and their families, but many of these forced separations just add another element of stress to the whole transition process.
Well, again, thank you for sort of shedding some light on this military transition theory. I think it's important that folks continue to keep this transition idea in mind throughout their care and treatment of veteran service members. Turning now to the older cohort of veterans, we've talked a little bit about these veterans that are transitioning out of the military recently, but we also have apparently these elder veterans who appear to be at higher risk of suicide. And I saw that you termed the coin Hemingway Effect, or used the term at least. Could you explain that for us?
Well, yes. One of the high-risk groups dying by suicide looks to be sort of the older white males. And old white men are rarely looked at for any kind of health disparities or behavioral health considerations. The focus tends to be on the young, tends to be on other minority groups. But from a veteran perspective, when a veteran takes their life, I don't really care what color they are or how old they are. It's a tragedy, and I think we need to be mindful of it. And some of the early data we were seeing looked like 60-plus, 65-plus year old veterans were dying at an unusually high rate of suicide. And we term this the Hemingway Effect to sort of acknowledge that, Ernest Hemingway also took his life. And when you look at the life of Ernest Hemingway, and when he did take his life, he had all of those risk factors associated with someone dying by suicide. He was a veteran, by the way. Most people are not aware of that. He was a veteran. Two, he had severe health issues later in life, primarily from being in two near fatal accidents and plane crashes. Third, he had this sort of genetic disposition. His mother had died by suicide. There was a lot of mental illness in his family. Fourth, a lot of his friends were dying. And around the same age, as you get older, your friends start dying. And fifth, he started becoming disconnected with those around him. So in other words, he started becoming isolated. He stopped having those close relationships, those friendships, that social network around him, that how we talk about is so important when you join the military, establishing new friends. When you leave the military, again, establishing a nice social network of people who understand you. So he was feeling disconnected. He was feeling hopeless. He had already received his Nobel Prize in Literature. He was world famous. So he kind of thought he had peaked. There really wasn't much left to look forward to. And his dying by suicide, though, was a very different transition process than these earlier transitions that we were talking about, but it was a transition nonetheless. And so it kind of highlights that you don't say, oh, well, you've been out of the military now for 10 or 12 years, you're probably fine, because there's going to be these other transitions that happen later in life that we also must be mindful of. And that was kind of our point in highlighting Ernest Hemingway as an example, because we know so little about our elderly veterans. It's really a shame, and it's one of those research gaps that we need to really close as quickly as we can, because today's veterans will become older veterans, and we need to do everything we can to make that whole transition also as smooth as possible for them.
Well, that was extremely well said, and I do think using Hemingway as an example was really good, and I didn't know he was a veteran either. So, again, just really sort of gave a great picture in my mind. It, unfortunately, of course, a very tragic picture, but does paint that picture and helps to sort of identify this group, at least epidemiologically, that is at higher risk of suicide. And this need for most focused interventions to reach our elder veterans. So again, thank you for highlighting this military and transition theory and how it really just applies to veterans and service members across the entire lifespan. And again, that's really helpful, and hopefully our clinicians listening in will sort of start to, or if they already are, just continue to think about transitions as an important opportunity for prevention of suicide. Colonel Castro, I did want to touch on some of your more current work with military families, because I think sometimes we focus almost too much on just the service member, just the veteran, and how important it is, again, within this social network and your family being one of the biggest pieces of that. Could you tell us about your work with military families?
So one of the things about military families is, and there's, I always like to tell folks, there's the military family that people think of, and that is the family that you had with you while you were on active duty. And that's what people tend to think of as a military family. But they rarely think of a veteran's family that they acquired after they left the military as really part of a military family. But as we all know, and as research is showing, that those veterans are different, and how they approach relationships now is fundamentally different, having served in the military, and in particular having served in combat. And they will have children. And these children may not be, quote, military brats, but they are impacted and affected by their parent who served in the military, either because of things they saw and did in combat, because of any mental and physical health issues they may have suffered from serving in those combat operations. But that's going to fundamentally change how they raise their kids and how they interact and relate to their children. So we think it's very important that the children of veterans and the spouses of veterans really become a centerpiece of research where we can begin understanding how does being married to a veteran influence your health and well-being and the health and well-being of your children. And we're just now really begin looking at that, those relationships.
Well, we certainly look forward to hearing more about that work, and appreciate you for joining us today, and just wanted to give you sort of a platform to give any closing remarks or advice or ways to move the suicide prevention field forward.
No, one of the things that, if I could leave anybody with any final thoughts, it would be sort of how we started, and that is when the military saw these increases in suicides that were happening, and primarily in the Army and the Marine Corps, but the Army primarily, we didn't know what was causing those increases. Historically, the suicide rates in the Army and DOD have been very, very low relative to civilian rates. But I'll be honest, we didn't know why they were low. We didn't know why the suicide rates in the Army were lower than why they were in civilians. Now, we had ideas. We said things like, well, it's because there's better leadership. It's because they have a worthwhile mission. It's because the military generally recruits healthy people. When the suicide rates started going up, we didn't say they were going up because of poor leadership. We didn't say they were going up because of a useless mission or that our service members were any less healthy. Instead, we started bringing in new explanations, combat, family histories, genetic, not enough fish in the diet. All of these other explanations began creeping in. And my point of saying this is we don't know why they were low, and then we had no idea why they were high, because we really have no idea what causes suicides. And because we don't know what causes suicides, this led to a variety of interventions that the DOD, the Army, the Navy, the Air Force, the Marines, everybody has their own suicide prevention training program. Well, that should tell you right there that we don't know what we're doing, right? Because if we knew what we were doing as the Department of Defense, there'd be one training program that someone had been shown effective for everybody. But in point of fact, we just started developing interventions without testing them, without seeing whether or not this results in the lowering of suicidality, and then, of course, ultimately dying by suicide. And this is why it's so fundamentally important that we conduct the necessary research and conduct the necessary trials to actually show what we're doing to reduce suicides actually does. Because we still do not have a validated suicide prevention program that we can point to and says, this will prevent someone from dying by suicide. And that's an important point because leaders and clinicians will often, well, we got to do something. But I always go back to something that Admiral Nimitz said after the Pearl Harbor fell, Guam fell, the Philippines fell. And he said, there's no problem so great that a bad solution will do. And it's this mindset that it's better to do nothing until we know what we're going to do works. That is really the best approach. Because a decade later, we're still trying to figure out why are suicide rates still high in the Army and what can we do about them. Because we weren't disciplined enough to do those careful studies right from the beginning to where we could actually be having some answers if we had done a more systematic, thorough approach. So I'd like to just leave everyone with that thought. Let's make sure what we're doing works.
Well, thank you for that thought. And again, thank you for being on all these research advisory boards to help push the suicide prevention agenda forward and making sure that we do have quality, sound evidence to back up our decisions on this important topic. So again, thank you for your time today.
My pleasure, and thank you very much for having me.
Absolutely. Well, that'll be it for the RMIREX Short Takes podcast today. And listeners, we appreciate you for joining us. You can certainly learn more about Colonel Castro and a lot of his work by clicking on the link that we will post with the podcast. Again, feel free to reach out to us with any comments or questions about what we discussed today. Take a moment to subscribe to the podcast, give us a review, and share with your colleagues. Until next time, we will be back for more important interviews on work and suicide prevention.